Good morning, everyone. My name is Dr. Carloman Escobar, and today I will give a brief lecture on one of my favorite subjects, multiple sclerosis. Now, let's begin asking ourselves, what is multiple sclerosis? It can be defined as a chronic, inflammatory, and immunologic disease of the central nervous system, that is, the brain and the spinal cord. It has a vast array of clinical presentation. That means that it can manifest as issues with your gait, problems with your sight, or even seizures. We can say that this is a progressive disease because eventually there will be cumulative damage in the neurological system that will lead to a significant impairment. Let's talk about some of the risk factors associated. Now, being part of the female gender can increase 2 to 3 times the likelihood, as well as being Caucasian. The onset of the disease lies between 20 to 40 years old, and it has been associated with a family history, with the presence of the haplotype HLA-DR2, and more recently with the mutation in the interleukin 2 and interleukin 7 receptor. It's interesting that there's a predilection for locations at high latitude, such as Canada, Northern Europe, Northern USA, and Southern Australia. And what I found interesting about this fact is that people who migrated to these regions before they were 15 years old had the same risk as those people who had always been resident in those areas, which tells us there's something more than just a genetic component. And that leads us to environmental factors, such as the exposure of the Epstein-Barr virus, patients who smoke, and the presence of vitamin D deficiency, which has been linked to a lack of exposure to the sun. And as we all know, we require the sun to activate the vitamin D in our bodies. Let's talk a little bit about pathophysiology. What is going on in this disease? So there is a triggering event that causes alteration in the humoral and cell-mediated immunity, and the own body starts attacking the central nervous system. Now, during the first clinical event, we're gonna see inflammation and the disruption of the blood-brain barrier, and an infiltration of B cells, T cells, and even macrophages into the central nervous system. All of these leads to the direct attack against oligodendrocytes and a deposition of antibodies, especially directed against myelin. These would lead to the presence of demyelinating plaques in the white matter. And in the absence of this sheet that covers the neurons, we're gonna see a blockage or a reduction in the conduction of the saltatory nerve conduction, and a reduction in its velocity. Eventually, after multiple attacks, it can actually lead to the destruction of axons and the transections of neurons, which will lead to a significant neurologic disability permanently. Now, before talking about the symptoms, let's talk about how MS can be divided according to the evolution of the disease throughout time. We have the most common, that is relapsing remitting, which is characterized, like in this picture, with episodic clinical events that can partially or completely recover, followed by a period of inactivity until again there is another episode. We also have secondary progressive, which it's especially common after long-standing relapsing remitting subtype. We're talking 10 to 15 years. So we have these episodic clinical events, and then we start seeing a steady progress in the neurological disability. We also have primary progressive, which is especially common in a late onset MS. We're talking 40, 50 years old. And from the beginning, we can see a steady decline, a steady and a rapid decline. And finally, we have the progressive relapsing, which has the worst prognosis of all. And we can see both the steady decline as well as episodic moments where the symptoms worsen even more. Now, clinical presentation, what are we looking for in these patients? We have to keep in mind that some of the initial manifestations of the disease include both sensory and motor symptoms. When we're talking motor symptoms, we're talking about a damage into the pyramidal tract. And when we're talking to sensory symptoms, we can link it to lesions within the lateral or posterior spinal tracts. Now, some of the more interesting and characteristic signs in the disease include the Lermite sign, which is a shock-like sensation in the cervical spine that travels all the way downwards, and it's especially triggered by the flexion of the neck. And another characteristic is the Umpton phenomenon, which is a worsening of the symptoms upon a hot environment. We're talking like a hot shower, exercise, or even fever. Because the disease affects white matter, we can cluster some symptoms to try to localize the disease within the central nervous system. And we're gonna get characteristic syndromes like optic neuritis with a diminished visual acuity, with eye pain, especially with eye movement. And like we can see in this picture, if we perform an eye fundus examination, sometimes we can find swelling or pallor in the optic disc. We also have transverse myelitis with motor and sensory symptoms, cerebellar presentation with tremors and nystagmus, and very common, we can find brainstem damage, whether it be the mesencephalus, the pons, or the medulla oblongata. And it's characterized with facial weakness, vertigo, hearing loss, double vision, and a very characteristic manifestation called internuclear ophthalmoplegia, where there is a lack of coordination between the nucleus of the cranial nerves responsible for eye movement. So in examination, we're gonna find an asymmetrical eye movement. Now, some of the more persistent and even sometimes less inquired symptoms include bladder dysfunction, such as urge incontinence with an hyperreactive bladder, or overflow incontinence in a lack of contraction of the bladder. We also have some GI symptoms. Rarely, we see some sexual dysfunction. Patients also express a sense of fatigue and depression, and sometimes overlooked, they can also show some cognitive impairment, such as memory loss, impairment in attention, and a decrease in executive actions. Now, if we take these patients and we give them an MRI, what are we going to find? So we're going to look for an asymmetrical pattern of lesions, especially in the zones around the ventricles, in the subcortical white matter, in the corpus callosum, in the optic nerve, the brainstem, in the cerebellum, and in the spinal cord. And what we're going to see in these images is an hypertensive lesion in T2, such as this one in the picture. And if possible, we can give intravenous gadolinium contrast, and we're going to see an enhancing lesion, both of which express a direct recent event. That means a recent inflammatory lesion. And characteristically, we can also find in a sagittal view some hyperintensive lesions called Dawson's fingers that travel all the way through the corpus callosum, which is very, like I say, characteristic of the disease. Now, if we don't find anything in the MRI, we can also perform lumbar puncture. And what the cerebral spinal fluid is going to tell us is that there is a mild elevation in mononuclear cells. There's a high EGG index, the presence of myelin basic protein, but most important, we're gonna find 2 or more oligoclonal bands. That means B cells that we wouldn't otherwise found in plasma, which is telling us that there is a localized active inflammatory reaction. Having all this information from the patient, we can move to diagnosis using the McDonald criteria. And we need to complete the requirements for time and space. That means that in time, we're gonna require 2 or more clinical attacks. That means 2 or more events lasting more than 24 hours with a separation of at least 1 month in between. And the requirements of space tells us an objective evidence of 2 or more clinical white matter lesions. Now, what happens if we can't fulfill this criteria? So we're gonna go, for example, what if we have 2 events, but we only have evidence of 1 lesion? So we need to complete the requirements for space. So we're gonna go to the MRI and we're gonna look for 1 or more lesions in 2 out of the 4 typical places where the disease hides, which is the periventricular zone, the juxtacortical zone, the infratemporal zone, and the spinal cord. Now, on the other hand, if we have an objective evidence of 2 lesions, but we've only had 1 event, that means this is our first time the disease appears, we are going to go back to the MRI and we're going to look for the presence of simultaneous enhancing, which is an active lesion, and non-enhancing lesions, which we could say are old lesions within the brain, or we can do a follow-up MRI and expect new lesions to appear. Finally, what can we offer the patients? So we need to keep in mind there are 2 types of medication. The ones given during the acute attacks, which include corticosteroids such as methylprednisolone, and in a lesser extent, if it doesn't have an effect, we can use plasmapheresis. And we also have the disease-modifying agents, which help us modulate the inflammatory response in this disease. So there is, they can affect in a wide manner. For example, interferons and glatiramer acetate can decrease the expression of T helper 1, that, as we know, is an pro-inflammatory cell. We have fingolimod, which blocks the exit of B cells and T cells from lymph nodes. We have natalizumab, which decreases the migration of inflammatory cells through the blood-brain barrier. And we also have a direct attack against B cells with rituximab and ocrelizumab. So what I found most interesting about this disease is that we don't have exactly a cause, a specific cause. So there is a potential for investigation. And we also haven't found the perfect medication. And even we haven't found a way to reverse the damage that has been done in the central nervous system. So it shows a wide possibility of investigation in the future. Thank you.
Okay. You done? No.
Yes.
Okay, great. Let me stop you.